presentation on updates about cancer-associated thrombosis, and hopefully that will provide some new insight on the management of this disease in your clinical practice. So my name is Marc Carrier. I'm one of the hematologists at the Ottawa Hospital, and we were able to get Agnes Lee out of retirement to join us for the Q&A today. So she was not overly keen in participating, but did a lot of work with the formatting and content of the slides, so we're very appreciative of that. And we also have Dr. Cynthia Wu from the University of Alberta in Edmonton, and we'll go through some challenging cases together, and hopefully we'll be able to generate a good discussion during the Q&A. So these are relationship. Agnes was supposed to do the initial slide, but since she's retired, I'm doing that now. So the program has received support. This is from Neo Pharma in the form of unrestricted educational grant. This program has received no in-kind support. The speakers are eligible for an honorarium from Thrombosis Canada, and Neo Pharma benefits from the sale of product that may be discussed during this program. The content, though, was developed by Agnes, Cynthia, and I, reviewed by Thrombosis Canada, and recommendation involving clinical medicine are based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in the program in support of justification of patients' recommendations are conform with generally accepted standards. So what we would like to do over the next 40-45 minutes or so, and have good time for discussion, is to explain the epidemiology and clinical relevance of venous thromboembolic disease, have a refresher. Is it common? Is it increasing? Is it associated with morbidity and mortality? Then if it is, then if patients have venous thromboembolic disease, what are the tools that we can use to tailor anticoagulation based on specific patient population? And then we'll summarize the evidence on the efficacy and safety of the different anticoagulant management, but through very challenging cases that you and I and all the panelists are facing on a day-to-day basis in clinical practice. So I'll start to provide a little bit of an overview, and before starting, these are my disclosures. And we all know that venous thromboembolic disease is not very common in the general population. We're usually thinking about 1 or 2 per 1,000. But as soon as you have a cancer diagnosis, you're increasing the odds ratio by 4-fold. And if that particular patient is initiating chemotherapy, the odds ratio increased to 6.5-fold. So venous thromboembolic disease is very common in patients with cancer. And it's nicely illustrated in this observational study using data from Denmark. And they were able to identify 500,000 patients with a first diagnosis of cancer, match them with 1.5 million without a diagnosis of cancer, and follow them over 20 years. The first thing you're noticing here is the difference between the two curves, right? So the 6-month risk of having VTE is 12-fold higher in patients with cancer compared to general population. And if these patients are undergoing systemic therapy or chemotherapy, then this is 23-fold higher. And the second thing that we're seeing here is that the curve is increasing over time. So this is not a problem that is going away. It's something that we see more frequently over time, associated with a higher risk or higher calls from your colleagues to help them manage cancer-associated thrombosis. So a 3-fold higher risk over the next 20 years, over the past 20 years. And for patients undergoing chemotherapy, it's a 6-fold higher risk of having venous thromboembolic complications. Now, it's not only very common in patients with cancer or associated or increasing over time, it's associated with morbidity and mortality. If your patient has a deep vein thrombosis or pulmonary embolism, they'll need to be started on systemic doses or therapeutic dose of anticoagulation, which is associated with a higher risk of recurrent VTE compared to non-cancer patients, higher risk of bleeding, both of which are associated with decreased quality of life independent of the scale you're using. Some observational data are saying that cancer-associated thrombosis is an important cause of mortality in patients with cancer, equal with infection, just following tumor progression per se. Obviously, these patients will need to be treated, so there's an increase in resource utilization, all-cause healthcare costs. And it's something that we don't talk as frequently. It's often associated, it's a very traumatic and distressing experience for patients and families, and often an additional stressors. It reminds patients that they're vulnerable. They already have a lot on their plate with their underlying cancer treatment and management, and adding this can increase stressors for them and their loved ones, also financial stressors if they have troubles having coverage for the different anticoagulants. So it makes sense that if it's common, its associated morbidity and mortality. As doctors, as clinicians, we want to minimize these morbidities and mortalities, so we want to find the right tool or the right anticoagulant for the right patients. And as you know, there's been a lot of development in anticoagulation over the years, and I've highlighted this morning that in the early 2000s, the Clot trial was really changed practice over time. That's the first time that we randomized patients to low molecular weight heparin monotherapy to vitamin K antagonist. And you can see over time, over the early 2000s, 2010, a number of 6 randomized controlled trials have randomized patients with different low molecular weight heparin to different low molecular weight heparin or vitamin K antagonists. They've all showed that it's decreasing the risk of recurrent VTE, not increasing the risk of major bleeding, maybe decreasing the risk of clinically relevant bleeding, so a combination of major bleeding and clinically relevant non-major bleeding. And we have data that this is actually working very well. This is data from Laurent Bertoletti from France using the Riette registry overall. You can see on the left-hand side the trend in the type of anticoagulant used from the early 2000s until 2018. You can see that low molecular weight heparin use has been increasing over time. And on the right-hand side, you're seeing the actual clinical impact of this. And you can see that we've been doing better. We've been decreasing the 30-day overall risk of recurrent VTE, decreasing the overall 30-day risk of major bleeding, so decreased morbidity and hopefully mortality in patients with cancer. Now you can see that both scales are finishing around 2018, which is actually the year that Hokusai VTE cancer was presented, and we started using direct anticoagulant for the management of cancer-associated thrombosis. So Laurent and colleagues will have to have a look again what happens from 2018 to 2024, but I'm hopeful now that we have so many different options, we're able to tailor anticoagulation appropriately and hopefully decrease morbidities more so. So I mentioned that in 2018, Hokusai VTE cancer was published. As you know, there's now 6 randomized controlled trials comparing different direct anticoagulant to low molecular weight heparin. And on the left-hand side, you're looking at efficacy. So patients receiving direct anticoagulant had a lower risk of recurrent VTE compared to those with low molecular weight heparin, a relative risk reduction of 33%, an absolute difference of about 3%. This may come at a cost of increased risk of bleeding complication, maybe a slightly higher risk of bleeding, major bleeding complication, a relative increase of about 20%, an absolute increase of less than 1%, but certainly comes at an increased risk of having clinically relevant non-major bleeding, a relative risk increase of about 65%, and an absolute difference of about 4%. So you just see now it's not as a slam dunk as when we did the trial comparing low molecular weight heparin to vitamin K antagonist, where we had a clear benefit, no increase in arm. When we look at direct anticoagulant compared to the low molecular weight heparin, sure, we're getting some efficacy, but that may come with a little bit more headaches on how to tailor anticoagulation to avoid bleeding complication in these patients. And then remember that these are patients participating into randomized controlled trial, right? So in clinical practice, we see a lot of other patients that have additional comorbidities that we need to take care of. This is a nice prospective cohort study from Isabelle Mahé and colleagues in France. They followed patients in their clinical unit over time, over 300 patients, and they asked themselves the simple questions. How many of these patients would actually fit the eligibility criteria for randomization into Hokusai VTE cancer, comparing edoxaban to low molecular weight heparin, or Caravaggio comparing apixaban to low molecular weight heparin? And you can see that when you look at the inclusion criteria, about 50% of people we're actually seeing in real life wouldn't meet the criteria, sometimes because they don't have a type of clot that would meet the inclusion criteria, so there was a lot of upper extremity deep vein thrombosis, for example, but they also had additional comorbidities like anemia, thrombocytopenia, brain tumors. These patients were not necessarily included based on different levels. Patients that are doing poorly have increased or worse prognosis with increased ECOG and some renal failure. And the reason why I'm saying this is that we need to be very mindful that sometimes extrapolating clinical trial data into the real world, we need to be mindful of really looking at baseline characteristics and maybe tailoring anticoagulation accordingly. So based on these results, we'll go through a case. So we have Mr. MT. He's a 71-year-old gentleman with metastatic castration-sensitive prostate cancer. He's on androgen deprivation therapy with apalutamide, and he has a new diagnosis of multiple segmental PE. He has no other real comorbidities. His weight is 65 kilograms. His complete blood count and renal function are reasonable. I put a creatinine clearance as borderline just to spice things up a little bit. But otherwise, you would probably feel comfortable initiating anticoagulation in this particular patient. So what type of anticoagulation would you recommend? And this is not morning reports. I can't really force you, but I would love it if you would participate and raise your hand. So you have different DOACs, so apixaban, dabigatran, edoxaban, rivaroxaban. I've put them there in alphabetical order. Or would you use low molecular weight heparin? So who here would feel comfortable using apixaban? Okay. Who would feel comfortable with dabigatran? We don't really use it. There's no data in the setting of cancer-associated thrombosis. Who would feel comfortable with edoxaban? Edoxaban, I like it. Anybody else with edoxaban? Who would feel comfortable with rivaroxaban? Oh, you guys like apixaban a lot. And what about low molecular weight heparin? Who would do dalteparin? Thank you. Enoxaparin? Tinzaparin? It's a symposium by Leo Pharma. Thank you. Thank you. Okay, so I think we feel comfortable using a directal anticoagulant in that particular setting, and because of the baseline characteristics we've seen, and based on the randomized controlled trial data that we've seen. And that is somewhat consistent with the American Society of Hematology clinical practice guidelines. Remember, there's two recommendations for the acute treatment of cancer-associated thrombosis. The first one is referring to the initial 5 to 7 days. So they make a recommendation to use a low molecular weight heparin or a directal anticoagulant, because remember, if you want to use edoxaban, you need to use 5 days of low molecular weight heparin prior to starting edoxaban. If you want to use apixaban and rivaroxaban, you can start with these agents on day 1. So recommendation 20 is use one or the other depending on the setting. And recommendation 23, in a short-term treatment, so the initial 3 to 6 months, the recommendation would be a directal anticoagulant, or suggesting would be a directal anticoagulant over low molecular weight heparin, conditional recommendation with low certainty in the evidence of the effect. When you're in clinical practice, guidelines are helpful, but they don't really help you to make a treatment decision for an individual patient. Because we saw that, the directal anticoagulant would be associated with low risk of recurrent VT, but higher risk of bleeding. So what do I do in clinical practice? The first thing I think about is what is the bleeding risk of the patient. This patient has prior history of bleeding, high-risk lesion. Is there thrombocytopenia? Is there severe renal or liver dysfunction? And then depending on these, then I may decide to use a low molecular weight heparin over a directal anticoagulant. Second thing I do is type of tumor. You all know that post-OCUS-IVT cancer in SELECT-D, there's post-hoc analysis looking or stratifying patients according to if they have a GI tumor or not, and those with GI tumor were higher risk of having major bleeding complication, mostly upper gastrointestinal type of bleeding, so we tend to be mindful in that. And a GU cancer is because there's an increase in 65% of clinically relevant non-major bleeding. A majority of these are GU-related bleeding, so we need to be mindful because the DOACs may make increased risk of bleeding. Drug-to-drug interactions is important, and then if all of these are taken care of, then maybe we can use a directal anticoagulant in that particular setting. The reason why I put out drug-to-drug interaction is I'm wondering if our patient, Mr. MT, has an important drug-to-drug interaction that we didn't really clue it into, and what are the possible consequences of this. So drug-to-drug are very common in the setting of cancer. Our co-chair, Dr. Sufei Wang, has done a retrospective cohort study looking at how frequent the drug-to-drug interactions are for patients with cancer receiving anticoagulation. And then you can see that if patients are on the directal anticoagulant, higher risk of having drug-to-drug interaction compared to low molecular weight heparin. Now, drug-to-drug interaction was defined by the lexicon with a criteria of C or more, so to make sure that it's somewhat clinically significant. Does this lead to important risk of recurrence or bleeding is still unknown, because this was a very small sample size, but highlights the fact that for as clinician, we should probably be mindful of it. because you all know that the direct anticoagulant have less drug-to-drug interaction than warfarin, but still more compared to low molecular weight heparin. They're dependent on the CYP3A4 and the glycoprotein P and all sorts of other pathways within the liver that may increase or lower the level of the direct anticoagulants in the serum. And therefore, if you have lower level, then maybe this would be at high risk of having recurrence. And if you have higher level, then maybe you're increasing the risk of having bleeding complications. There's 4 pieces of information available looking at drug-to-drug interactions specifically in the setting of cancer-associated thrombosis. The ISTH TAC DOAC registry looked at 200 patients specifically on targeted anti-cancer therapy. The retrospective analysis that I mentioned before with 300 patients, retrospective cohort studies, all are showing that maybe some of these drug-to-drug interactions are important with specific couple of drugs. The post-hoc analysis of Caravaggio is very informative and reassuring, but when they looked at the presence of it being on anti-cancer treatment or not, it's really all sorts of drugs, so it's really hard to figure out if there's important drug-to-drug interaction, and I know there's a lot of pharmacists in the room, and that's important to look into specifically. Now, I've put this because this was a big initiative by Corey Leblanc from Toronto and colleagues, pharmacists, looking at drug-to-drug interaction between direct anticoagulant and androgen receptor agonist new therapies. And what you can see here is, remember, our patient was on epidemiology, and then when you look at drug-to-drug interaction, there's an important drug-to-drug interaction with the direct anticoagulant. So these are agents that we're using more frequently in a setting of cancer-associated thrombosis, in the setting of prostate cancer. So it's just to be mindful that I'm not saying that maybe there's an increased risk of recurrence or increased risk of bleeding. We don't necessarily have the data saying there's clinical consequences, but the problem is that we have so many options now that why not use an option that would not have this potential drug-to-drug interactions. And I would highlight that it was impressed when I did the slides for the presentation. Now the article is available, so I would welcome, or I would suggest that you go to have a look, and it's a very interesting publication. A lot of pharmacists have done this. So because we're mindful of the drug-to-drug interaction, we're starting therapeutic dosing of low molecular weight heparin, tenzapirin 12,000 units sub-Q daily. 3 months later, the cancer has progressed. The epidemiology was discontinued. After discussion with the patient, low molecular weight heparin was transitioned to a direct anticoagulant. And to go with the family or the whole crowd, I picked apixaban at a dose of 5 milligrams PO BID. Now, the weight has decreased a little bit. There's complete blood count and creatinine are still within normal limit. The creatinine clearance is decreasing a little bit. Patient has now completed 6 months of anticoagulation. In your office, having a discussion. So would you recommend secondary prevention for this patient? Would you stop anticoagulation? Would you continue? And if you decide to continue anticoagulation, would you use a direct anticoagulant or low molecular weight heparin at therapeutic or at prophylactic dosing? So first option, who here would stop anticoagulants? No one, okay? Who would do low molecular weight heparin at therapeutic dosing? Okay, low molecular weight heparin prophylactic dosing. Remember, you were all wrong that the first time. Who is doing the DOAC at therapeutic dosing? Okay, we're starting to see people. And then who would do DOAC at prophylactic dosing? Okay, so I think we have an even split between DOACs at therapeutic and prophylactic dosing. And I think the first thing to remember is that we're now, the initial clot is cured, right? The rationale for continuing anticoagulation is for secondary prevention of a recurrent event. So we had a big debate, a big discussion, a good discussion about anticoagulation before. So what are the risk factors for recurrence? What are the risk factors for bleeding? And try to come up with the right risk-benefit ratio, including the patient's preference, along with availability and quality of life, and also prognosis. Is the patient at the end of life or not, which is not the case for Mr. MT just yet. So if you're interested into this, Kristen Sanfilippo did a fantastic narrative review published in the British Journal of Hematology that would suggest that you read when you have some time. The good thing is you could have picked anything, it would have been just fine. So there's data supportive of therapeutic dosing low molecular weight heparin, prophylactic dosing low molecular weight heparin, therapeutic dosing of DOAC, prophylactic dose of DOAC. So until we have a randomized controlled trial helping, then it's more or less your clinical gestalt that will make you decide which one you're using or not. This is just the data looking at therapeutic dosing of low molecular weight heparin. These are two studies, Delta-CAN on the left-hand side, TCAT on the right-hand side, looking at low molecular weight heparin from day 1, the diagnosis, up to 12 months. And their primary analysis was to look at the major bleeding rate in the second 6 months compared to first 6 months, so no comparator, single-arm, prospective cohort studies. You can see here that the risk of major bleeding was relatively small in the second 6 months, or comparable to the one that we had initially, and the risk of recurrent VTE seems to be relatively high despite anticoagulation. So indirect evidence saying maybe we should continue a little something because the underlying risk of VTE is still present. They would be at high risk of recurrence otherwise. We also have data looking at therapeutic dosing of anticoagulation with a directal anticoagulant. Remember, the Okusai VTE cancer followed patients for 12 months. So they did a similar thing, post hoc analysis comparing the second 6 months to the first 6 months. Remember, patient received therapeutic dalteparin or therapeutic edoxaban, but similar findings, relatively low risk of major bleeding, relatively high risk of recurrent VT despite anticoagulation. Again, no controls or no patients that stopped anticoagulation. On the right-hand side, the SELECT-D second randomization. So remember, SELECT-D compared rivaroxaban to dalteparin for the first 6 months. They actually had a second randomization as well, randomizing patients with index PE or residual vein obstruction on baseline ultrasound to rivaroxaban 20 or observation, and follow them over time. Small numbers, because often patients and providers have strong preference at that time, so they didn't really feel like randomizing patients, so they had to stop inclusion. But we still have 92 patients, and you can see that if patients continued rivaroxaban 20, seems to be effective, no difference in major bleeding or clinically relevant non-major bleeding between the two groups. We have a little bit of the data looking at prophylactic dose of apixaban, 2.5 milligrams PO/BID. This is data from Norway. They treated patients with apixaban 5 BID up to 6 months, and then everybody was dose decreased to 2.5 BID and followed over time. Again, no control group, but then when you look at the risk of recurrent VT and major bleeding in these cohorts, you can see that they're relatively low, so it seems to be safe and effective in that setting. Now, we want to see randomized controlled trial, right? We've been waiting for EpiCAT, but last year at ISTH in Montreal, the EVE trial was presented, published in a JTH. Remember, it's a small trial, powered for 65%. Maybe the initial estimates for the risk of recurrent VTE and major bleeding may have been a little bit over-enthusiastic, but it still provides us with point estimate that we can use in clinical practice. It was a superiority trial looking at major bleeding as the primary outcome measure, comparing 2.5 to 5. So you can see that the conclusion is that apixaban 2.5 is not superior to apixaban 5 milligrams PO/BID in that setting, but you can see you still have a relative risk reduction. And then when you look at risk of recurrence, it was 5% into both groups, combining venous and arterial events. So although it's not definitive data, it provides us with point estimate that maybe we can use when we have a patient and can use to educate them. Of course, we'll have more data when we have EpiCAT. The last follow-up was in September 2024, where we were hopeful to have data for ASH. It's not going to be possible, so maybe the ACCP or ISTH next year. But this is a well-powered non-inferiority trial comparing 2.5 to 5 milligrams PO/BID for secondary prevention of recurrent VTE in patients with cancer-associated thrombosis that already have received 6 months of oral anticoagulation. So at the 6-month mark, we make a decision. The group was split between 5 and 2.5, and that was just fine, but we decided to decrease the dose to 2.5 milligrams PO/BID for secondary prevention. Patients require hospitalization for general deterioration. After discussion with patient and family, he'll be transferred to palliative care for end of life. His weight has decreased a little bit. His creatinine clearance is borderline. CBC and creatinine are otherwise reasonable. So what would you do? Who would now stop anticoagulation at the end of life for transfer? Some people. Okay, who would switch to low molecular weight heparin? Harder to eat, maybe. Parenteral, maybe easier. No one. Who would continue DOAC at the prophylactic dose? Okay, and who would switch from low molecular weight heparin to DOAC if they had started or at therapeutic dosing? Okay, so most of people would either stop or continue the prophylactic dose of the DOAC. And again, there's no right or wrong reason here, but I thought I would highlight something that has changed my clinical practice over time. And Simon Noble's a palliative care doctor doing cancer-associated thrombosis research in the United Kingdom. He's the one that did the hidden study looking at asymptomatic DVT for patients that are in hospice for end of life. In this particular study, it's a small study, there's limitation because it's observational, but close to 500 patients with cancer-associated thrombosis followed over time, and they just followed if the anticoagulation was discontinued, when it was discontinued, and was that associated with risk of bleeding or risk of recurrence. And you can see here that most of the patients actually continue anticoagulation until the very last week or days before they pass away. And then in these particular patients, they don't have major bleeding, but they have clinically relevant non-major bleeding, about 5.5%. In those that stopped anticoagulation, there was no signs, symptoms of recurrent VTE, or the clinicians didn't really think it was a fatal event taking them. So I used to be a person that would continue anticoagulation because I was afraid of having a recurrent event that could alter or make the symptoms that could jeopardize the end of life. But now that I'm seeing the data, I think maybe I was causing more trouble with my anticoagulant. I tend to stop anticoagulation when they're at the end of life. But again, this is observational studies, and patient's preference and discussion is obviously warranted. So for this particular patient, we made a decision to stop. He peacefully passed away, no bleeding complications. And then I'll turn this over to Dr. Wu just to spice things up with more challenging cases.
Hello, everyone. I did get possibly a more challenging case. I don't know if I should hold everyone else's name in vain, or I should be happy I can just yap about whatever I want up here in the lack of evidence. But I'll go over a completely different case. This is my disclosures. I've done a few talks and ad boards for various anticoagulant companies. So here we have a 62-year-old man with non-small cell lung cancer who has unfortunately developed metastatic disease to both his bone and his brain. And he was sadly diagnosed with a proximal leg DVT recently. His past medical history is not really too remarkable, and the rest of I made at least his labs and his creatinine not in question at this time, so we can just focus in on some of the more harder questions. So for a man like this who has metastatic disease, including intracranial tumor, we listed off again a whole pile of different options for anticoagulation, including the bottom one, which is no anticoagulation at all. So again, similar to Mark, I'll just list off the numbers and I'll see who would like to use what agent. First one is apixaban and its regular therapeutic dose. Anyone volunteering for that one? I see a couple of hands. Next one is dabigatran with its normal low molecular weight heparin lead-in. Don't see anyone there. Next one, nadoxaban, also at its normal regimen. See a couple of hands up. Rivaroxaban at its normal regimen. Don't see anyone. We're all haters of rivaroxaban, maybe. Dalteparin at also its normal dose. See a couple hands over there. And enoxaparin. Don't think I see anyone. Tinzaparin. See a few more hands as well, scattered across the room. And anyone for no anticoagulation? Do not see any hands. All right, awesome. So let us try to delve through the evidence. So this slide may look familiar because it is the exact same recommendations that Mark had presented on his side in the cancer-associated thrombosis ASH guidelines. Unfortunately, there's nothing that specifically looks at patients with brain tumors, either metastatic or primary. So we're really still flying a little bit on expert opinion. To be honest, if you look at the grade of evidence for these, some of you could argue that all of these are expert opinion, but in the brain tumor world, unfortunately, we have even less data. So what do we actually have? If we take a look at the clinical trials that were done, these are just some of the major clinical trials comparing direct oral anticoagulants to low molecular weight heparin in the cancer-associated thrombosis world. And you can see that unfortunately we're kind of down to around 1% of the patient population or less was brain tumors of any kind. And in one of the studies, apixaban study, they completely excluded patients with brain tumors, so we don't really have at least randomized control data on brain tumor patients. So what else can we rely on here? We do at least have some data that has been reported. This will now go into more retrospective looks or cohorts, so not controlled trials. So there can be obviously a lot of bias in who was picked onto which medication. But at least we have something that we can look at and hang our hats on. In this particular study, they took a look at just the incidence of any intracranial hemorrhage as well as the major intracranial hemorrhages in patients with intracranial tumors who were treated for a thrombotic event with either a direct oral anticoagulant or a low molecular weight heparin. And you can see that, unfortunately, there is bleeding rates. I don't think we're shocked at that. And the lines seem to be a little bit more split in the upper portion, the patients who have major intracranial hemorrhage. But again, these are relatively small numbers. I don't think we can draw a direct conclusion as to which agent is better. But again, does show that there is some bleeding that is associated with anticoagulating these patients. In this particular graph, I think on your left, so my right side, I would show patients with primary brain tumors, and then on your right side, which is my left, patients with metastatic brain tumors. Again, the top is major intracranial hemorrhage, and the bottom is any intracranial hemorrhage. Again, cancer-associated thrombosis patients with brain tumors, of course. And the orangish line is the low molecular weight heparin, which in this case was enoxaparin, and then the dotted blue line is a direct oral anticoagulant line. And interestingly, it seems like there might be a difference between primary tumors and metastatic tumors, but again, these were extremely small numbers. You can see 20 patients, 40 patients, so probably not enough to draw conclusions on, but it was just an interesting difference, whereas the metastatic lines look a little bit more similar to each other. So at least something to have a bit of a baseline to kind of leap off of. Hopefully we can get some more robust data in the future as we collect more information. But there has been some more recent attempts at getting more patients that have these so we can report better numbers. So the anticoagulation in brain cancer study, which is a retrospective cohort study, or the ABC study, is designed to try to collect patients with brain tumors of any kind at the time of their VTE diagnosis and the start of their anticoagulation. And the main purpose is to follow these people for about a year to see what their incidence of complications are, but then also to see when they do get an intracranial hemorrhage, what happens to them. So what do we do clinically? Again, it's not a randomized trial. This is just to see what in real life practice people are doing. Do they restart or not, and what happens to patients in the different categories, and to again follow these people out for a few months after their intracranial hemorrhage. So this was, so I should credit that these slides were from Dr. Leder's group who presented this over at ISTH recently, and so I borrowed a few of the slides from that talk. So this is just some of the baseline demographics. They did get 745 patients in total, so it's probably the biggest cohort of brain tumor patients that we've been tracking on anticoagulation for their VTEs. And there is a little bit of flip-flopping of numbers back and forth between DOACs versus low molecular weight heparin. Again, relatively small numbers, enough that we probably can't draw a direct conclusion, but at least it's helpful to see that they did have a fair number of primary versus metastatic cancers. For whatever reasons, there's more male patients by quite a lot in the primary category and a bit more of a 50-50 in the metastatic category. The age range was about the same in the mid-60s. History of VTE seemed to be a little bit more in the low molecular weight heparin side and probably reflected in newly starting anticoagulation versus not. And the cancer diagnosis, the types of cancers are probably not surprising. Glioblastoma being the most common primary tumor, and then metastatic lung cancer being the most common metastatic cancer. So again, we may not have, full data and or, the robustness of thousands and thousands of patients, but I think we still at least have something to look at now in several hundred patients. And you can see that people do have ongoing bleeding events that do occur, which I don't think we're surprised about. We'll show some data later about some of the baseline risk of bleeding with these tumors, but there is some risk that additionally when you anticoagulate patients with either of the anticoagulants. Thankfully, the major intracranial hemorrhage rate and the death related to intracranial hemorrhage is actually very small. So we're not, actively killing large volumes of people if we anticoagulate them. And death, not shockingly, is mostly related to the cancer. Probably more, maybe not more importantly, but very important as well, is to note that these patients, despite being on anticoagulation, still have a recurrent thrombotic rate. And this number of, again, not being a randomized trial, but still giving us an estimate of in the kind of middle single-digit % range is actually very similar to the other cancer-associated thrombosis trials we have on DVT and PE, where the breakthrough rate on anticoagulation is probably about 4 to 5 times higher than in benign trials, where the breakthrough rate is maybe around 1%. So it's not an insignificant number. These patients are very thrombogenic and worthwhile to remember that. And they did actually track out arterial thrombotic events as well, too, even though that may not have been been a primary thing that we are treating for, and some patients unfortunately had arterial events as well. So bottom line would be that there is a high rate of bleeding compared to patients who don't have any intracranial risk factors, but thankfully the mortality is not relevant as much to the bleeding, and there is still unfortunately clinically relevant VTE that we have to worry about in these patients. So the bleeding clotting patient or the clotting bleeding patient, always the tough ones to manage. So this is a little bit of a graphical representation in case you don't like numbers, just to show the lines on what is going on here. And again, for whatever reasons, that primary brain cancer seems to have a slightly different split compared to metastatic, but with small numbers, hard to draw hard conclusions for these. So this here shows that, I think the first one, sorry, I skipped over the title, was for any bleeding, and this is for the major bleeding. So again, a very low line for major bleeding, thankfully, so at least the big events are things that we worry about, the ones that we worry about the most are not occurring as frequently. So that the ultimate thoughts on just anticoagulation of brain tumor patients. Again, we do see that there seems to be maybe a little bit of a trend, at least in some patients, that there's less bleeding in the DOAC side. Even in the randomized trials, with that 1% of patients that I had mentioned, there may have been slightly less numerically intracranial hemorrhage bleedings and possibly even some of the bigger events in the DOAC arms. But it's still very hard to draw that conclusion definitively, especially in the data I just showed, which is retrospective, because we can't control for what clinicians decide to do. Based on that bottom line on the slide here, a lot of people are still using low molecular weight heparin in these patients because we believe as clinicians if we can intervene quicker or if we can do something like adjust the dose or stop a medication as a shorter half-life in a high-risk bleeding population, so not just brain tumors but thrombocytopenia, people who've had prior bleeding or active bleeding, recent bleeding, we always feel like slightly more comfortable about ourselves if we can make some adjustments along the way. Whether that's the right thing to do or not, whether we have a lot of evidence to support that that's safer or more effective, I can't say that, but I say that we all feel better when we can do something along the way. And so a lot of times we are still skewing towards using low molecular weight heparin in these higher risk patients. So it is possible that in these retrospective studies, the patients who were given low molecular weight heparin were already pre-selected to be slightly higher risk for bleeding. Hard to say. Worthwhile, hopefully one day we'll have some more prospective data and we'll be able to confirm one way or the other. But at least for now, we have the data that we have presented that again shows that different patients will be on different anticoagulants, and there probably isn't a huge difference between what you pick at the end of the day. So going back to this, this was just a slide that was also shown earlier in the presentation. It was originally designed in 2018 as a guidance document for cancer-associated thrombosis with special situations discussed within Canadian groups of cancer-associated thrombosis experts, and then updated in 2021 to include a little bit more of the direct anticoagulant data. And while we highlight some of the bleeding risk factors at the very top that might skew you towards low molecular weight heparin, it is obviously still with the grain of salt that the evidence is not very strong. We don't have a lot of big trials in any of these areas. But again, the adjustability of the medication sometimes leads us to pick one over the other. So in this case, this man was started on dalteparin at the regular dose, and unfortunately, a few months later, he comes back in with some shortness of breath, chest pain, and then was found to have a new PE, despite what you think is appropriate treatment. The rest of his lab work and everything else is relatively stable, so nothing too exciting going on there. So in this situation now, so in a man who has been anticoagulated for a few months, who now presents with what you think might be a breakthrough event, what would you do now? So again, we'll poll the audience. Would you switch the patient to another class, like a direct oral anticoagulant? A few people I see raising their hands. Would you dose escalate the current low molecular weight heparin and or split the patient to a BID regimen? I see a lot of hands, so people seem confident on that one. Switch to a different low molecular weight heparin. That's 3 and 4. Is anyone willing to just change the low molecular weight heparin? No one there. Switch to warfarin. Hopefully not seeing a lot there. And then some people, would you just not change anything? Just keep going as is. No one for that one either. All right, let's see if the evidence supports what you think. Unfortunately, there is very little out there, so I can't even quote a guideline because it hasn't made it into guidelines. There are certainly some guidance statements, as I mentioned, but there's no formal guidelines that would tell us exactly what to do when people break through their anticoagulant therapy. I think despite that, though, there are some common sense things that we can all agree on, is that you should probably rule out things that are not necessarily a drug failure, because that might be an easy answer. I have an example of a patient I saw recently. I saw him about 8 or 9 months after his index event. He wasn't referred in until later, and it was more a duration of anticoagulation question at that point. But about 3 to 4 months after his event, it was a cancer patient. He had developed a recurrent event, and so plastered all over his chart was that he had failed tinzaparin. They switched him to dalteparin at its normal therapeutic dose. So whether you agree with that or not, that's what was done. And so everyone was basically classifying him as a very high-risk patient because he had broken through treatment. So when I took a history on this guy, I wasn't, fishing for anything. I just asked him what was happening in, the couple weeks prior to him getting his recurrent PE. And he just forwarded very easily that he had felt better from his initial event. So he started taking his low molecular weight heparin every other day. And he just didn't tell anyone prior to that, and I guess no one asked. So obviously it wasn't necessarily an anticoagulant failure. He may have just been a patient who is either non-adherent, or sometimes a dose is prescribed wrong. Maybe the patient was not weighed properly at the beginning. There may have been other interruptions along the way for surgery. Our cancer patients, a lot of things happen to them. They get procedures, lines, and so forth. So there may be some very easy to explain reasons as to why this patient failed their anticoagulants that may not require you to do anything different, except just restart and or continue their anticoagulation. But obviously there are a lot of patients in the cancer world who just break through. We definitely know, even from the earlier slides, that the breakthrough rate is probably somewhere around 5%-ish on anticoagulation, and so there are real breakthroughs out there. So again, while we don't have randomized trials or a lot of really solid data, we have had several groups who've looked at just different strategies on how to manage a breakthrough event. And it does include, some of this is a bit older, so VK we're still there, the vitamin K antagonists were still there. And so switching someone over to an alternative class of medications versus escalating the dose of the low molecular weight heparin. And in most of these, it was escalating to about 20-25% of the dose and splitting to a BID regimen. The BID regimen is really, in theory, there to maybe address the trough levels that occur, since low molecular weight heparin has a very short half-life. So we're trying to minimize that kind of drop-off at the end of 24 hours with an extra dose every 12. And you can see that, well, again, not a randomized trial, we have some numbers there that show, again, that the recurrent, that's the next recurrence rate. So now we're looking at like your third event, so your second recurrent VTE, is kind of roughly around that 5%-ish range, which is what we would call kind of like a recapture of control. We know that if we don't anticoagulate an PE or DVT at all in the acute phase, you're kind of getting more like a 40 to 50% rate of recurrence. So being able to drop that number back down to what we see after a first event and starting anticoagulation, we feel like we've recaptured control of these, and in the absence of any other randomized trials, it looks at least encouraging that escalating the dose of low molecular weight heparin, which is probably practically speaking what most people do, or switching from an oral drug to a low molecular weight heparin, is reasonable. And again, the theory behind switching in some classes might be if you truly believe there is a biologic or pharmacologic reason why one drug has failed. So maybe they can't swallow or digest food properly, and you don't think they're absorbing things, or they're having a lot of vomiting and nausea, they can't get oral anticoagulants in, or whatever's happening to them, they have needle phobia and they don't want to be on their needles. Whatever you think there is some reason why switching the class of the medication might help, potentially can also be used as well too. So this man was dose escalated to 10,000 units twice a day, which is approximately that 20-25% dose increase. Then he, unfortunately, continues to be complicated and causing us all sorts of problems. Comes back in now with an acute subdural hematoma, which was symptomatic. The rest of his blood work looks fine. In the acute setting, of course, he was appropriately stopped on his anticoagulation at the time of his intracranial hemorrhage. Then, of course, the question now remains, what are you going to do with him in the future? So maybe not right now, because I think we all agree he should have his anticoagulation stopped now. But would you ever consider restarting the anticoagulant? And let's see what the audience would do. So in this case, would you just permanently discontinue anticoagulation? Who's in that boat? I see 1 or 2 people. Who half rose their hands, so a lot of uncertainty. Would you restart the anticoagulation immediately? Because this guy's now had a couple of blood clots along the way. Is this too high of a risk to not anticoagulate? Yes, he is not in the end stages of life yet. The question was, is he kind of in the palliative, hospice kind of setting? He is not quite there yet. Obviously, he's not curative intent therapy with his metastatic disease, but he's not at the end of life yet. No one restarting right away. And now I know I put a few just random time points there. Is there anyone who would restart after a week, say, for example, from the intracranial hemorrhage? I see a hand over there, Who would restart after, say, maybe 3 weeks, a month, somewhere's in that range? I see a few hands. Who would wait another 3 months, so a bit longer? I see a couple hands up. And I put the grab back at the end, where you just do it case by case. See a lot of hands there, people who do not want to commit, fence sitters. So probably the right answer, though, as with most things in medicine, we can't really paint everyone with the same brush. But let's see what kind of evidence does exist. Unfortunately, very similar to the last section, we don't really have a guideline statement out there that tells us exactly what we're supposed to be doing. So we're going to have to wind our way through what does exist out there, which thankfully is not nothing. We do actually have a little bit that's out there. So this really just takes a look at what the rates of, again, this is not a randomized trial, these are just kind of reported numbers, what the rates of having the major types of complications we worry about, which is rebleeding into the brain, recurrent VTE, and then ultimately survival of these patients. And this is in cancer patients, so at least we have some data now, which is relatively new, so we have something to look at. I think what's important is that we recognize that if we re-anticoagulate a patient who has an intracranial hemorrhage, the risk of rebleeding is higher than if you don't anticoagulate. But what's important on this slide is the rate of bleeding without anticoagulation is already 4%. It's 6% with anticoagulation, but not all bleeding is related to the anticoagulant that you put on board. So these patients do have a baseline risk of bleeding either way. If we take a look at the next box, you see the recurrent VTE rate, which is unfortunately a lot more starkly different. I don't think this surprises people. If you re-anticoagulate people, you kind of get down to that mid-single-digit % range that we were seeing before on anticoagulated patients. But if you don't anticoagulate somebody, then the recurrence rate is very high. And here, if you can't squint and see the numbers, it's around 35%. So it's about 4 or 5 times higher than when you're on anticoagulation. And so the split seems to be a lot larger than the potential harm you might be introducing with re-anticoagulating. And while the p-value is not statistically significant over on the survival side of things, the curve is a little bit in favor of re-anticoagulating people because, again, of that really large recurrent thrombotic risk, which we know in cancer patients is associated with the decreased mortality. So this is something interesting. Again, not a randomized trial. Numbers are still relatively small, but at least worthwhile to look at, because I think we have started looking at this question in non-cancer patients for a long time now, even in atrial fibrillation patients. I remember when I was a medical student resident, which unfortunately is very long ago now, even though it may not look it. I remember someone could trip on the sidewalk and you would take them off their anticoagulants because their bleeding risk was too high. But I think we realized that particularly for high clotting risk patients, like a high CHAD score patient for AFib, for example, that's probably not the right thing to do. And we're trying to more aggressively re-anticoagulate patients even after major bleeding events. Obviously sensibly, and not everyone should be re-anticoagulated, but I think we're starting to move away from no one should be anticoagulated after a major bleeding event. We recognize that the thrombotic complications in high-risk patients is always there, and the net clinical benefit might still favor re-anticoagulating even after very terrible things have occurred to a patient. So, in summary for this particular case, I know I delved into probably not a lot of hardcore evidence, but hopefully at least a little bit of ways of thinking about things and highlighting at least some of the newer data that's come out in the retrospective cohort realm. I think we can all agree that intracranial tumors are very hard to deal with because they are the bleeding clotting patient. They are up there on the top of the list in terms of tumors that cause clotting, but unfortunately the type of bleeding is also the worst kind of bleeding that we worry about. But I think in all the data that we have so far, it seems like for at least most cases, I can't say all, that the recurrent thrombotic risk might be higher than the recurrent bleeding risk, and thrombosis in a cancer patient, unlike previously when you heard the debate where the case fatality of bleeding in the non-cancer population is 3 or 4 times higher. I think of some of the emerging evidence that's coming out in cancer, the thrombotic death rates, the case fatalities are more significant in cancer patients. So there's always that to weigh out in the back of our heads as well too. And so I think we just have to kind of, again, it is a case-by-case, sure, but I think with a lot of talk with the patient, reviewing of whatever guidance statements are out there and trying to update ourselves as the data evolves, we can try to wind our way through taking care of these complex patients. And probably one thing, which I don't think I put on the slide, but probably is a worthwhile thing to take away, is that these are the kinds of patients that you want to follow up closely. So you don't want to just send them home on whatever you did and see them again in a year. You probably need to see them relatively frequently to make sure that whatever decision you made is the right one. And if something something has happened to the patient, you can intervene earlier and make adjustments. And with that, I think I'm happy to answer questions with the rest of my panel.
So, Dr. Field. Yeah, sorry, Aggie, I have a burning question after Dr. Wu's presentation. So, neuroimaging is such an important biomarker for us in terms of judging risk of ICH and kind of outside of this malignancy context and hypertension control. Is there data on kind of neuroimaging markers on susceptibility weighted or GRE MRI, like hemosiderin staining, microbleeds, cortical superficial siderosis, stuff like that?
That's a very good question. I admit that I am not an expert in neuroimaging, so I may not be able to interpret things very well, but I have seen some studies that have tried to report different parameters of the intracranial hemorrhage. So not just the size, obviously the size is something that is very commonly reported, but other features that might suggest a higher risk. I cannot say that I'm expert enough to be able to comment on that data as to whether or not clinically it would help me make that decision. I would then probably defer to neurology, neurosurgery to help me interpret, which is something that probably is worthwhile to highlight as well. A lot of these patients who are complicated have complications that are beyond, say, hematology or thrombosis, and does require a bit of a multidisciplinary approach so that we're all treating the right thing. I might be able to tell a neurologist or neurosurgeon what the thrombotic risk is related to their cancer, but I may not be able to tell these exact questions, what is the bleeding risk related to these imaging findings. So have a discussion with multiple disciplines I think is worth it so that we can all put some input in and help the patient get to the right place.
Like your guy with the subdural, like repeating his neuroimaging is critical in making that decision, to find out if it's been resorbed or not. And the other thing is, now there's middle meningeal embolization for chronic subdurals as an option to reduce his risk.
Awesome, thank you. I think Mark had
There's a little bit of...
I asked him to turn off your mic.
I know you did. There's a little bit of evidence from the ABC registry, so again, small numbers, but they did look at MRIs and the imaging they had at that time, and then the only thing that they could figure out as a low risk was hemosiderin deposition didn't seem to be associated with a high risk of recurrence bleeding in that particular patient population, but still abstract and needs to go through peer review.
As a general internist who often sees people on the first diagnosis of potentially metastatic disease and intracranial bleeding, especially with VTE history, is there evidence to support the timeline of when these bleeding events happen with respect to the initiation of anticoagulation? Let's say if they started, a trial period of low molecular weight heparin for a certain period of time, does that kind of challenge them enough to say, okay, it's reasonable to switch them to DOAC, acknowledging that there were certainly differences that showed potentially a lower bleeding risk with DOACs, but is there a timeline associated with that where we might be able to suggest we can switch them?
It's a good question. Is this on? Okay, awesome. That's also a good question. The question that I think we grapple with for not just intracranial hemorrhage, but probably a lot of other bleeding sites as well, is have you road tested the patient long enough? Even in GI cancer patients, have you road tested them long enough, and now you can put them on a DOAC even if they haven't had their surgery yet? I don't think there's probably an exact number because it will depend on what the tumor is, where it is, and what treatments are going to be given, because some treatments can certainly shrink down cancer, cause maybe some necrotic tissue and so forth. But there probably is a bit of a timeline if the patient is otherwise stable and has not had new growth, new metastatic disease, or any other treatments in between. And I would say that if we look at some of the data on anticoagulation in general, the highest risk of bleeding is always within the first 1 to 3 months because you are exposing a risk of bleeding that was there, a background risk. So I think if you road test a patient for a few weeks and they haven't been bleeding and they're really struggling with a low molecular weight heparin, you could probably start thinking about the possibility after a discussion with the patient to switch them over. That would just expert opinion. I don't know if anyone else wants to comment up here, but that's where I would go.
I completely agree with what was said. I was just going to highlight, when I showed you DeltaCAT and TCAT, you can see the first month was on purpose not including the analysis because the risk of both recurrence and bleeding is highest. So I agree, it depends on what happens in the course, but probably that the first 4 weeks are the highest risk.
Thank you.